welcome all the audience and to introduce the first section of this VIS meeting. The first talk is given by invited speakers from Professor Thierry Passeron from Nice, France, and the title of his presentation is Oral Gliadin-Protected Superoxide Dismutases in addition to phototherapy for treating non-segmental vitiligo, a 24-week prospective randomized placebo-controlled studies. Please, Thierry.
Dear colleagues, first I would like to thank the organizing committee for inviting me to give this talk on the role of oral Gliadin-Protected superoxide dismutase in addition to phototherapy for treating a non-segmental vitiligo. Here are my disclosure, but importantly, the study has been a lot thanks to a grant from Isocell Laboratory, but the sponsor didn't have any role in the analysis or conclusions of this study. We all know here that vitiligo is an acquired repigmentation of the skin and hair, affecting about 0.5 to 2% of worldwide population. Interestingly, it has been demonstrated that there is an incidence risk ratio in true twins of 25. If we are looking at the mother, it's 426, and to the father, 336, which is quite interesting to see that there is an increased risk in the mother if the mother had vitiligo as compared to the father. We'll come back to this later. Many very beautiful GWAS studies have been performed, and they demonstrated that there are approximately more than 50 genetic variants for vitiligo. However, there is also a delay in the age of onset of vitiligo, emphasizing that environmental factors are also playing a very important role in triggering the onset and the flares of vitiligo. Recently, the group of Bordeaux and Rome nicely reviewed the pathophysiology of vitiligo, but they emphasized their review in the role not only of the immune part, but they clearly demonstrated that there are many evidences emphasizing that the skin of the skin, meaning the melanocyte, the keratinocyte, but also in the dermis, the fibroblasts, are also altered in vitiligo and are actively playing a role in the pathophysiology. They emphasize that there are strong evidences showing that in those cells there is an increased susceptibility to oxidative stress and increase of production of radical species. And they also demonstrated that there's a secretion and also some evidences suggesting that there is alteration in the mitochondria. And I remind you that if the mother has vitiligo, there is an increased risk as compared to the father, and it might be due to the fact that it's the mother that is giving the mitochondrial DNA. In our part, recently we demonstrated the key role of the innate immunity, especially in the starting events. And we also demonstrated that melanocyte at their surface express CXCR3B, which is a receptor different from the CXCR3A that we are finding in immune cells, for example. And when the activated innate immunity produce interferon gamma chemokines such as CXCL10, for example, it's binding to CXCR3B receptor and inducing an initial apoptosis of melanocyte. And the remaining melanocytes are presenting their own antigens, meaning that when the CD8 are coming to the cells, they are targeting those melanocytes that are presenting their own antigens, leading to the onset of vitiligo. And we can prevent those initial events if we are using CXCR3B antibody. We made this study with my colleagues Merik Turik, and I think it's very important because it's emphasizing that at the beginning, this innate immunity is making the link between the external stressors factor and the activation of the adaptive immunity. And with my friend from Bordeaux, altogether, we recently reviewed the key role of the innate immunity in vitiligo. I won't go into details, but it's clearly showing that there are on top of genetic factors, the environmental factors such as leading to stress, oxidative, but also physical pumps coming from, for example, from bacteria will activate this innate immunity. And this innate immunity will make the bridge between those factors and the activation of the adaptive immunity against melanocyte. And this leads to many potential therapeutic targets. I won't go into details, but if you are interested, you can look in this review. Very importantly, a few years ago, we also demonstrated that in vitiligo, there is a decrease in the Wnt pathway in the skin of patients. And it's very important because this Wnt pathway is responsible for the differentiation and the migration of melanocyte stem cells. And this is key for repigmenting the vitiligo. And importantly, we demonstrated that if melanocyte, but also keratinocyte are affected by oxidative stress, it will decrease this Wnt pathway and thus preventing repigmentation of the lesional skin of vitiligo. In general, when we want to target vitiligo, it's very important to keep in mind that it's much more complicated, for example, as compared to psoriasis, because in psoriasis, if you target the inflammation, the immunity, the skin will heal. In vitiligo, of course, you have to target the immune component, and this will lead to this will halt the melanocytic loss, meaning that you will prevent the depigmentation. And this is allowed by NB-UVB, but also calcineurin inhibitor or steroids, and more recently with a JAK inhibitor that will hopefully provide much better results for halting the depigmentation of the skin. But what is also very important to keep in mind in vitiligo is that, of course, you have to prevent the depigmentation, but you have also to induce the repigmentation. And to this respect, you have to induce the differentiation and the proliferation of melanocyte. And this is only possible so far with UV coming from the sun or artificial sources. And this is a very long process. It takes 6 to 24 months, and we have to really explain that to our patient. Last but not least, we know that after 1 year, there is 40 to 50% of relapses, and thus we have to use treatment to prevent those relapses. So what is the role and the potential interest of antioxidant for treating vitiligo? As I mentioned, there's a well-demonstrated role of oxidative stress in vitiligo, but there are only few evidences of the true clinical efficacy in robust clinical trials. A very nice recent meta-analysis reported that indeed there are conflicting results of the use of antioxidant in treating vitiligo, and most importantly, oftenly supported by low evidences studies. And their conclusion was that there are for sure potential interests of antioxidant in vitiligo, but we clearly need confirmatory studies. And to my opinion, this discrepancy between the clinical efficacy and the very solid fundamental evidence could be explained by the differences of effectiveness between all antioxidants, because of course all antioxidants has not the same efficacy, and also because of that most of them, if not all, have a digestive degradation leading to very poor biodisponibility. So what about superoxide dismutase? The SOD is a key enzyme for in the antioxidative machinery of the cell. It is the first antioxidant mobilized by the cells. It catalyzes the dismutation of the superoxide anion, and it decreases the oxidative stress as well as the downstream activation of inflammatory mediator, which could be very important in disorders such as vitiligo. However, as I mentioned, oral administration of SOD, but also other antioxidants, is ineffective under normal conditions, since those enzymes are deactivated when they are past the gastrointestinal tract. And it has been demonstrated that if you combine the SOD with a wheat gliadin biopolymer, it's protected from this degradation. And this has been supported by very solid studies in animal models, but in human, that confirm that this gliadin-protected SOD is better than placebo and other antioxidants in neuroprotection, atherosclerosis, and UV-induced erythema. So we thought that if one antioxidant could be interesting in vitiligo, this could be this GP-SOD. So to summarize, the potential mode of action of this GP-SOD is that, of course, they can decrease the production of inflammatory cytokines such as interferon gamma and 6CL10 by decreasing the activation of innate immune cells. But as I mentioned, the oxidative stress is also playing a role in decreasing the Wnt pathway. So by fighting against this oxidative stress in combination with a UV, we might promote the repigmentation of the skin by allowing a better differentiation and migration of melanocytes. So we made a prospective randomized double-blind placebo-controlled study in our university center in Nice, in the south of France. We included 50 patients with vitiligo affecting more than 5% of the total body surface area. One group received the GP-SOD, the name in France is Glycodine État Général, 2 pills in the morning and two at noon, 30 minutes before lunches for 3 months, and only 2 pills in the morning for 3 additional months. The other group received placebo, and both groups, of course, received an urban Photo-UVB twice a week. The evaluation was performed by 2 independent physicians blinded to the treatment received. Here is the flow chart of the study: 25 patients in each group, 2 follow-up in the GP-SOD and 3 in the placebo group. But of course, all the patients were included in the intention to treat analysis. Here are the characteristics of the patient, mostly skin type 2, 3, and 4. What is very important to keep in mind is that the duration, the mean duration was more than 20 years, and almost all the patients had already failed to at least 1 line of treatment, meaning that it was a very long-lasting and resistant population. And here are the results, and I have to say that I was quite surprised to see such a good result. There was already a significant increase in the GP-SOD group after 3 months, and it was even better, reaching up to 20% of repigmentation after 6 months. And if we are looking at the VIS 50, meaning the proportion of patients achieving 50% of pigmentation in all over the body, we can see that for VIS 30 and VIS 50, there is much higher percentage of patients reaching those rate of pigmentation in the group receiving UV and GP-SOD as compared to the group receiving placebo and UV. And of course, and not surprisingly, the tolerance was very good, and there was no side effect due to the treatment. So the conclusion of this study is that GP-SOD significantly increases the percentage of repigmentation after 6 months of phototherapy, 20% in the group receiving the GP-SOD as compared to less than 10% in the group receiving only narrowband UVB. And I remind you that the population we treated was patient with old and resistant form of vitiligo, so we can expect to have better results in a group with milder or new vitiligo, and the tolerance was very good. So in conclusion, of course, this GP-SOD has not to be used in monotherapy, but to my opinion, it's a very good treatment in addition to phototherapy and other drugs in treating vitiligo, and it's very useful for our patient, because so far we clearly need to increase the rate of repigmentation in our vitiligo patients. So I would like to thank you for your attention. I will be happy to answer if you have any question. Thank you very much.
Thank you very much, Thierry, for this very nice presentation with a nice introduction on the